So we're going to talk about the regulation of blood pressure. Now, there's lots of players involved in here. Our heart, our peripheral arteries, places in the brain like your cardiac regulatory centers and your vasomotor centers. The lungs even have a role, the liver, the kidneys, and then, more parts of your brain like the hypothalamus and glands like the pituitary gland and the adrenal glands. It's a lot going on. So let's start in the beginning. How does our body measure its own blood pressure, right? Because we can measure a patient's blood pressure with a blood pressure cuff on their arm or their wrist, an arterial line directly measuring the pressure. But how's your body do it, right? On a day-to-day basis, right? Minute to minute, hour to hour, and regulate your blood pressure from going too high or too low. We have special areas of cells here where the carotid arteries split. So this is your aortic arch. On the right, we have a subclavian artery and a common carotid that are splitting off what we call brachiocephalic trunk or the innominate artery. And then the left common carotid just splits directly off the aorta. Do you need to know that for this? No. So that's my CCA, I get my ECA, and my ICA. Okay, just a quick anatomy sidetrack. So off the aortic arch, so you get common carotid, external carotid, internal carotid. So here, brachiocephalic trunk splits to the right subclavian, and then the right common carotid, which splits into the right ICA and ECA. So near that split of the ECA and ICA off the CCA, we have these areas of cells. Okay, and these cells, we call this the carotid sinus. And these are baroreceptors, which are mechanoreceptors, which basically are measuring stretch. We also have some stretch receptors in the aorta, and we have some in the right atrium, and that all gives feedback to the brainstem to determine, what are we going to do with blood pressure and cardiac output and all that. We're going to have to get into that later, okay? So we're measuring the amount of stretch. If there's a lot of stretch, that's going to send action potentials back to the brainstem and say, hey, blood pressure is going up, or it's too high, or whatever. And there's less stretch, well, then blood pressure is going down, right? So this is going to send action potentials via nerves to the medulla. I'm just going to make this very simplistic, right? And there's a couple centers in the medulla. There's the cardiac acceleratory center, the cardiac inhibitory center, and then the vasomotor center. So we'll just put some generic areas of nuclei here. We're not going to go over all those details in this video. And this is coming back from the carotids, mainly through cranial nerve number 9, or the glossopharyngeal nerve. All right, so that's how we're monitoring blood pressure. Now the question is, well, what do we do with it? Well, we can do a couple of things from a cardiovascular standpoint, right? We have the heart as an effector. We have the arteries as an effector. So in the heart, well, we know about the autonomic nervous system. There's the sympathetic, or the fight or flight, and there's the parasympathetic, or the rest or digest. So if blood pressure, let's say, is going too low, let's say, so let's find the green marker. If blood pressure is going too low, well, the cardiac acceleratory center can say, ooh, we need to speed this heart up. Why speed the heart up? Because cardiac output from the heart is going to be directly proportional to blood pressure. So this is going to say, okay, let's send some nerve signals out to the nodes and to the myocardium. All right, and what's going to happen? So sympathetic outflow onto the heart is going to speed the heart up. Okay, these nerves are going to drop off norepinephrine. They're going to bind to adrenergic receptors on the heart, and they're going to have two effects. So the sympathetic stimulation is going to have a positive, we call chronotropic effect. So chronos means time, in I think ancient Greek. So positive chronotropic effect. Well, that's going to make the heart beat faster, increase your heart rate. Okay, so positive chronotropic effects, this is going to increase your heart rate. And we're also going to have positive, we call ionotropic effects. Iono meaning ions. So again, this is going to improve the movement of ions, and this is going to increase contractility. The heart's going to squeeze harder, and we know that's going to increase stroke volume, right? And if we take a step back, remember, well, what's cardiac output? What's the formula for that? It's heart rate times stroke volume. So by having sympathetic stimulation, here, these sympathetic nerves, right, these are sympathetic nerves, we're going to get increased heart rate and increased contractility, which is going to increase our stroke volume and heart rate, and it's going to increase your cardiac output. If you increase cardiac output, you're going to increase blood pressure. Now, what if we want the opposite? What if blood pressure is going too high and we're saying, hey, we need to slow this heart down? Well, green will be for go, right? We're going to send signals here from the medulla, and this is going to be parasympathetic nerves, and mainly through the vagus nerve, cranial nerve number 10, but we'll just write cranial nerve 10, which is parasympathetic, and that's going to drop off acetylcholine on the cholinergic receptors on the nodes of the heart, and it's going to tell the heart to slow down. So parasympathetic effects are going to have just negative chronotropy or negative chronotropic effects, which are going to decrease heart rate, which is going to decrease cardiac output, which will decrease blood pressure. So how does this work in real life? Okay, so blood pressure is going too high, let's say, because it's homeostasis, it's always going up and down a little bit, kind of wiggling in that ideal normal range. And more action potentials are going back to the glossopharyngeal nerve to the centers in the medulla. So we got the cardiac acceleratory, cardiac inhibitory, and the vasomotor. So if blood pressure is going too low, well, so there's less stretch, let's say there's less stretch, we're gonna stimulate the cardiac acceleratory center and say, hey, our blood pressure is dropping. So we're going to not only just stimulate the cardiac acceleratory center, which is going to send sympathetic signals to the heart, right? We're going to inhibit the cardiac inhibitory center, which sends parasympathetic nerves via cranial nerve 10, vagus nerve, to the heart as well. So we have to stimulate one and inhibit the other to get the effect we want. So if we're going to stimulate the cardiac acceleratory center, we have more sympathetic outflow, increased chronotropy, increased anotropy, heart rate contractility go up, cardiac output goes up, blood pressure goes up. In the meantime, we're going to inhibit this because we don't want heart rate to go down. So we have to kind of turn one on, turn one off, because we have this dual innervation. Now, if blood pressure is going too high, let's say, well, then we're going to have more action potentials going back from the increased stretch. We're going to inhibit the cardiac acceleratory center, so less sympathetic outflow. We're going to inhibit that. And we're going to stimulate the cardiac inhibitory center, which is parasympathetic nerves through the vagus nerve here, cranial nerve 10. And we're going to inhibit these effects, but stimulate these effects. Heart rate will go down, the heart won't contract as hard, and cardiac output will go down. If cardiac output goes down, then blood pressure goes down. So cardiac output is one of the first big pillars here. So if we increase CO, we're going to increase BP. If we decrease CO, we're going to decrease BP, as long as all other variables remain constant. Now, what about arteries, right? Well, same thing here. We're going to have a vasomotor center. The vasomotor center can only stimulate blood vessels. So this is going to be through other sympathetic nerves, which are coming down from the spinal cord, and they're going to release norepinephrine onto adrenergic receptors on the tunica media of blood vessels, the smooth muscle of blood vessels. And what's that going to do, right? It's going to cause vasoconstriction. So these are more sympathetic nerves here, so sympathetic. So the vasomotor center is going to send sympathetic signals, drop norepinephrine on adrenergic receptors, and cause the blood vessel to constrict. So we call this sympathetic tone. So if we increase sympathetic outflow, so if we increase the sympathetic effect, right, I can put it here, so increase sympathetic tone, well, what's this going to equal? If we increase sympathetic tone, this is going to lead to vasoconstriction, so vasoconstriction, and if we increase vasoconstriction, the diameter of our blood vessel is going to get smaller. If we make all the pipes in our system smaller, we're compressing the blood volume we have, we're going to increase pressure. Say you have a certain amount of water flow through the pipes in your house, and all of a sudden make your pipes just a little bit smaller, compressing that same volume of water in a smaller space. The pressure is going to go up. So shoving water through a smaller tube, pressure is higher. So that's how we affect our total peripheral resistance. So the other big pillar here for blood pressure is our TPR. So we have cardiac output, or CO, and then we have our TPR. Other things affect resistance. The thing we can control directly for the cardiovascular system is going to be the total peripheral resistance through sympathetic nerves. The opposing thing here, blood pressure is too high, well, we're going to inhibit the sympathetic nerves, have less sympathetic tone, and the blood vessels will vasodilate. So we don't have parasympathetic nerves to the arteries, okay? So targets are the heart and the arteries. Those are our two effectors that we can control through our cardiovascular system for blood pressure.